Cartwright. Thank you. Good afternoon, Ms Lamb. Ms Lamb, can I start with a new topic, please, international comparisons? And please, can we display your paragraph 191, which is at page 72, please? Now, you detail in the statement, in addition to cooperation, the United Kingdom has a seat as a member state on international organisations such as the World Health Organization and the World Health Assembly. While Scotland is not a member state, information provided by these relevant international organisations was provided to the Health Protection Network and the Chief Medical Officer. Can I ask then, please, had the Scottish Government undertaken any work relating to international experience and learning relevant to inform its test and protect, isolation and support preparedness prior to the pandemic?
So prior to the I'm not aware of what work had been done prior to the pandemic. As we started to be aware of the existence of COVID-19 in China.
Sorry, can I just interrupt you Sorry, Ms Lamb, can I just interrupt you? I don't know whether you're sat near the microphone. It's quite crackly, whether if you sit back. And sorry, you might want to start that answer again. I'm sorry for interrupting you.
No, that's quite all right. I think that there's maybe something around the connectivity, which is odd because it's been fine so far, but you're a bit broken up for me as well. But
I apologise. Please, if you can't hear me, please let us know. But if we're able just to continue, if you can persevere with the slight crackle, we'd be very grateful. Thank you.
Absolutely.
Do you want me to ask the question again, or are you able to provide your answer?
No,
Thank you.
I heard the question. Prior to the pandemic, I'm not really aware of how much engagement we've had because that would have been around the four-nation development of the pandemic flu plan. As soon as we became aware of the existence of COVID-19 through our Chief Medical Officer and, as it says here, through our Health Protection Network, colleagues were talking to other colleagues internationally. And in terms of how we specifically looked at how we set up Test and Protect, our establishment of Test and Protect was very much based around the WHO recommendations for a Test and Protect or a testing and contact tracing system. We also took, through our advisory groups, one of our advisory groups looked at a review done by the University of Edinburgh of international approaches that was around asymptomatic testing. And I'm aware also of another paper that was considered around how Slovakia went about whole population testing. So there was some formal consideration through those advisory groups of other international approaches. And at the same time, our Chief Medical Officer, through the four UK medical officers, but also through his own international links and their international links, kept very close to developments that we thought would be helpful for us overseas.
Thank you. Can I then please move to a new topic on communication, please? And can we go, please, to your paragraph 762 at page 266, please? Thank you. Now, you detail there that the expert reference group on COVID-19 and ethnicity was asked to provide advice and recommendations by the Scottish Government in relation to data, evidence, risk and systemic issues. And then you tell us about the two subgroups formed, one to review health data and evidence, and the other to examine systemic issues and risk. And you tell us that the work of both groups was underpinned by evidence of the risks that migrant and minority ethnic communities face in contracting COVID-19. Can I ask, given your role as Director for Test and Protect, how are the recommendations of the expert reference group incorporated into the design and delivery of the Test and Protect programme?
Yes, There was a full equalities impact assessment of the Test and Protect programme carried out pretty early on. So we worked through that process to look at the impact on different groups, including ethnic minority groups. The expert reference group, I think, brought to us that analysis and a recognition that our data wasn't good enough in terms of ethnicity. And one of their key recommendations, not just for the Test and Protect programmes, but for other programmes, was that we needed to improve the collection of ethnicity in our core health system, so that we were able to really review the data with a lens around ethnicity. And in fact, one of the things that we took forward as a result from that, not in the Test and Protect programme, but in the vaccination programme, was taking the opportunity when people came forward to vaccination to ask them if they were prepared to use that to disclose their engagement to disclose their ethnicity that would help us to get a more complete record across Scotland.
Thank you. Can we then move forward to your paragraph 795, please, at page 275? And you detail in this paragraph and the paragraphs that follow the partnership working that existed in the Scottish Government with NHS and Public Health Scotland colleagues, and also the Black and Ethnic Minority Infrastructure in Scotland, the Minority Ethnic Health Inclusion Service, and the Minority Ethnic Carers of People project, and the Scottish Public Health Network to develop the content of the fact sheet and the translated language list. And then you further give more detail of the efforts taken if we look at paragraph 797 and 798 again around the work done messaging and communication. And can I ask then, having looked at those matters, can you assist or explain how these working relationships developed and why it was considered essential to convene these specific organisations in response to the challenges posed by the pandemic?
So these were organisations that were trusted by ethnic minority communities who had a really good understanding of the concerns of those communities, and they were bringing to us issues around the extent to which our messaging was reaching those communities, and to the extent to which those communities had barriers and challenges in complying with that messaging and understanding what we were asking them to do and being able to do that. And I think some of the benefit that came out of those discussions were around how we were able to tweak our communications, particularly in things like self-isolation fact sheet, as we had that evidence that there were maybe poorer levels of compliance with self-isolation, and bringing to us some of the understanding around cultural norms. So, for example, in cultures where it's very much part of the culture that you gather together, that you visit each other, and that it might be considered very unwelcome for people not to stop you doing that. They helped us to be able to translate those messages and assist people to understand why we were asking people to reduce their gatherings, for example.
Thank you. And we look specifically then at paragraph 797, please, on page 275. You detail that minority partners highlighted that self-isolation messages were not being understood within the ethnic minority communities. You tell us that there was evidence that people were still going to work and sending children to school when waiting for test results, and also when testing positive. For those in extreme poverty, self-isolation was a huge challenge. And for those with no recourse to public funds, following the rules was extremely difficult and might mean their family would not have the essentials. Can I ask you, in that context, can you assist? And I appreciate we've asked a number of questions in the same context, but are there any other additional measures that you want to tell us about that were put in place to specifically address these concerns in Scotland, please?
So the first part around self-isolation messages not being understood, the measures that we took to try and address that was to work with members of those communities to understand how we needed to tweak our fact sheets, and that might have been about translating them into more languages. It might have been about slightly changing the way in which we were, the text that was involved in those, or the visuals that were involved in them. It might have been about presenting more information in a targeted manner through video clips and those sort of things. So we worked really hard to make sure that the messages around what you need to do if you're asked to self-isolate were as clear and as possible in the context of the cultural norms within those communities. And then in terms of that, the issues around self-isolation being a huge challenge for those in poverty, as I've already said, we made sure that the Scottish Self-Isolation Grant was available to those with no recourse to public funds, and we worked with relevant groups to make sure that people understood that that was available, and we also continued to ensure that the eligibility bar for those was lower in Scotland than elsewhere in the UK.
Thank you. And you've just referenced the work that was done on the self-isolation fact sheets. Perhaps for completeness, if we can look briefly at your paragraph 801 at page 276. Thank you. You detail there the languages in which the self-isolation fact sheets were created in and the various formats. And then if we can just look briefly at the follow-on paragraph, again, touching upon what you've told us about the audio-visual information in community languages. I think there's further examples there about how that particular tool was also utilised to assist with communication. Is that correct? Thank you.
That's correct, yes.
Thank you. And then finally, to complete the topic on communication, in light of the difficulties in self-isolation compliance, were there any lasting impacts or changes in policy regarding how the Scottish Government collaborated with minority ethnic organisations, especially in terms of communication strategies for future public health crises?
Yes, I think we learned a huge amount about communication strategies in general public health issues, but also for future public health crises. And I think that comes back to making sure that the messaging is really accessible, making sure that you are building trust and using trusted organisations to communicate with different communities, and really understanding the impact. In the case of this pandemic, it was around isolation. In another pandemic, we might be asking people to do different things, but it's about understanding the impact on different groups of what we're asking them to do, and then again making sure that access to testing was as easy as possible, and that was around targeting minority ethnic communities in places where they would feel comfortable to engage with a testing program, and equally in our remote and rural communities, making sure that we were using mobile units, Scottish Fire and Rescue Service and others to take tests as close to people as possible.
Thank you.
Ms. Cartwright, I'm sorry to interrupt. I'm being asked to break so this connectivity issue can be resolved. But for reasons I'm not going to go into, I'm reluctant to break this witness's evidence. So I'm just going to encourage everybody to focus on their questions. And this obviously applies to those core participants who have permission to ask questions solely on the issues that really do need to be highlighted in oral evidence.
If it assists, my lady, I've only got a brief question on scaling back and a one question on lessons learned. So we're nearly there with my evidence.
Thank you.
And I think there's been some indication that the TUC questions have either been shortened or reduced completely. So, my lady, I'm sure that's noted. Thank you.
Thank you very much. Sorry to interrupt.
No.
Your last question was about tests as close to people as possible, if that...
Thank you. I think we'd completed that. Thank you.
Ms Cartwright.
Thank you. Ms Lamb, thank you for your patience. Can I then move to my penultimate topic, please, scaling back of test and protect? And when I started the questioning with you on the very helpful chronology, we saw that being the end point of the relevant chronology on test and protect. Can we contextualise these questions, please, in your paragraph 206 at page 76? Paragraph 206 at page 76, please. Thank you. Now, we see detailed there the view of the First Minister at the time, Ms Sturgeon, on the 15th of March 2022, where she detailed, regrettably, our freedom of manoeuvre here is severely limited by the fact that our funding is determined by the UK government decisions taken for England. However, we have sought, as far as we can, to reach the right decisions for Scotland. It is important to note that we're aiming for the same long-term position as England on testing. However, we consider that the transition should be longer. In England, testing for people without symptoms ended in mid-February, and we will do so at the end of this month, that being the end of March. For those with symptoms, we intend the transition to last until the end of April. This is as far as we can go within funding constraints, but this does allow us to take account of current case numbers and better support the shift in our management of the virus overall. And so can we then together, please, giving the views of the First Minister around that decision, which we touched upon at the outset of your evidence, can we briefly look at the Test and Protect Transition Plan from March of 2022, which is INQ 235186. We could start on the first page, please, first of all, just to identify it. Thank you. And we could scroll down a little just so we can see it's badged as March of 2022. Thank you. And then if we could then move to page 9. And would you agree, Ms Lamb, that certainly the ideal plan that Scotland had hoped to have in place for the scaling back of Test and Protect was a plan, if we look at this plan, intended to have availability of lateral flow devices and PCRs from onwards to July of 2022 had the funds been available to permit the scale back in the way that Scotland would have liked to have done?
I'm not sure we've got the foundation for that question. I'm sorry to interrupt, Ms Lamb. It seems to be accepting what Ms Sturgeon says, and as I said earlier, I've had a fair bit of evidence on funding, and I've yet to hear evidence of an actual decision not taken because of the what Ms Lamb called the uncertainty of funding. So I think you... was this programme, Ms Lamb, this timeline affected in any way by the uncertainty of funding?
So, my lady, in this case, it wasn't about the uncertainty of funding. We had certainty and we knew that the funding was going to come to an end. So, Scottish Minister's views was that they would have liked to have had a more gradual transition plan out of the full-scale testing, but took the decision that that was only affordable up through to the end of April.
And then could I ask, please, Ms Lamb, I think, to look at the views also of Mr Youssef. Can we briefly look at his statement, which is 475071. That's 475071. Paragraph 157 on page 57, please. Thank you. Now we can see there Mr Youssef details that in early 2022 the UK unilaterally announced it would stop population testing for COVID-19 in England from April 2022 in most circumstances, and he characterised that this significantly reduced the available consequential funding for the Scottish Government and constrained the Scottish Government's ability to decide on the length and nature of transition of the Test and Protect scheme. And can I ask you, from your perspective as the Director General, do you agree with Mr Youssef's characterisation of this issue as detailed in his witness statement?
So as Director General and Accountable Officer for the portfolio budget, it is absolutely the case that the decision of the UK meant that Scotland would not be getting consequentials, and therefore that immediately put financial pressure on us in terms of needing to find money from other budgets in order to be able to continue to have a longer transition. And in practice, what that meant was that the transition was not as long as ministers would have liked to have been because of the cost involved.
Thank you. And so I suspect you've answered this question, but would you then agree that what this meant for Scotland was that the Test and Protect scheme in Scotland was brought to an end earlier than should otherwise have been the case as a result of the reduction in consequential funding available?
Yes, ministers would have liked to have seen a longer transition available.
Thank you. Now, you've again helpfully assisted with giving the latter part of your statement from paragraph 876 over to lessons learned, and so I'm not going to take you through what's helpfully set out from page 310 onwards, but can I ask you then briefly on one aspect that's a little earlier in your evidence, paragraph 239 on page 85, linked to lessons learned from data handling, please. That's INQ 587342, para 239. Thank you. Now, you've detailed within paragraph 239 that a wide range of data resources were relied upon by the Health and Social Care Directorate in advising and briefing ministers and working with other partners, including NHS boards, to inform policies and strategies of the various parts of Test, Trace, Isolate. Can you assist us with what lessons have been learned from the pandemic by the Scottish Government regarding data shortcomings, data gathering, availability and analysis relevant to Test and Protect, please, and particularly if anything else you want to say around Test and Protect in the context of isolating also, please?
Yes, so I think in terms of lessons learned, we absolutely learnt that we need to have access to multiple data sources and that we need to be able to join up that data very quickly in order to make sense of it. That meant that we had to work through some of the information governance requirements around use of that data, and actually that work continues today to enable us to ensure that the data that we have across Scotland for multiple purposes is being put to the best use in improving the services that we provide. So we continue to progress that work.
Ms Lamb, those are my questions. Can I thank you for answering them, but also persevering with the technical difficulties. There are some questions from core participants. Thank you.
Mr Doe.
Thank you, my lady. Ms Lamb, I ask questions on behalf of the Federation of Ethnic Minority Healthcare Organizations, or FEMO, and I have two short topics that I wish to explore with you. Firstly, in paragraph 781 of your witness statement, you mentioned the Scottish Government's Connecting Scotland's program, which aimed to provide laptops, devices, and Wi-Fi to individuals who were shielding or needed to avoid outside contact, which was introduced to address digital exclusion during the pandemic. My question is, how do you assess the role of digital exclusion in exacerbating health inequalities, particularly during the pandemic?
Thank you for that. So during the pandemic, I think as we were moving so much reliance towards digital, we were really acutely conscious of the impact of digital exclusion. The Connect Scotland programme was already in place, so that was already up and running, and we used that really to work with partners to try to ensure that we were reaching as many people digitally excluded as possible. From the perspective of this portfolio, health and social care, we had a real emphasis on shielding and also on people in care homes and being able to use digital to connect those people in care homes with their families and loved ones during the pandemic. Other portfolios such as education would have had more of a focus on the requirements for education. But the programme, I think the programme continues. It was important during the pandemic, but it predated the pandemic, and it continues today. And it's distributed, I think, somewhere around 36,000 devices, so iPads and Chromebooks, and also MiFi, so the remote connectivity devices, about 32,000 of them. So, and it is, as I said, it's an ongoing programme to ensure that people are not digitally excluded as a result of not having devices or connectivity, which is a bit ironic today. But we also need to ensure all the time that we're making other methods available so that people who are unwilling to or unconfident in engaging with digital can reach us as well.
Thank you. And it might be obvious, but how did the Connecting Scotland programme integrate with other initiatives such as Test and Protect to ensure that individuals who were digitally excluded could still access crucial public health services and information?
So the Connect Scotland programme focused on people who were shielding to enable them to access those resources, and also I think was a key part of ensuring that people in care homes could continue to remain connected as well. So those were the two big priorities from this portfolio's perspective, and we engaged with Connect Scotland to make sure that we were able to deliver on those.
Were there any particular challenges in reaching certain communities?
I think probably the challenges are the same as we've heard across some of this is about understanding where the challenges, where people are experiencing issues due to not having access to devices or connectivity. I think we recognise right from the start that care homes were a particular feature, and we had, I think, about 80 to 85% of care homes engaged with this programme in order to improve that connectivity. But yes, so there are always challenges in people understanding what's available to them and getting that messaging out.
And finally, given your leadership, how do you, stepping back a little bit, how do you or did you assess the impact of Connecting Scotland, the Connecting Scotland programme in bridging the digital divide for those in vulnerable and marginalised communities, particularly in terms of access to health services and public information?
I think that the Connect Scotland programme was and continues to be really important in providing an opportunity for those who are digitally excluded by virtue of not having access to the devices or connectivity. So that continues to be really important. I think that our focus, inevitably we focused on some key groups during the pandemic, and as I've said, 85% of care homes engage with that. I do not have data as to what the uptake was compared to what might have been expected in other vulnerable communities.
Very well, thank you.
Thank you, Mr. Dale. Mr. Jacobs, do you have any questions left?
My lady, thank you.
Thank you very much. And Ms. Mitchell.
I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. It's the experience of the Scottish COVID bereaved that patients were transferred within hospitals between wards and units without having been tested for COVID. Was there any guidance put in place to ensure that patients were being tested before being moved within hospitals?
Maybe my starting point here is the Scottish National Infection Prevention and Control Manual, which is maintained, kept up to date by High Scotland. That stands for the Antimicrobial Resistance and Healthcare Associated Infection Team. And that manual is the guidance that is used by NHS boards in relation to the prevention and management of infections, whether they're COVID or whether they're other infections. That's in I think January, around mid-January, 10th of January 2020, the UK there was a UK-wide COVID infection prevention control guidance issued through Public Health England, and over time that guidance was I suppose brought together and added as an addendum to that Scottish National Infection Prevention and Control Manual, because the guidance that was issued for England used terminology that was unfamiliar in Scotland, so we did some work to make sure that was understood. Within the constraints of that National Infection Prevention Control Manual is the guide. Each NHS board then needs to facilitate its own risk assessment and operationalise those procedures, taking into account their own specific patient pathways, but also the nature of their built infrastructure. I think that as well in terms of that definitions, so we also within those working procedures, the UK guidance specified that patients needed to be screened on entry to hospital, and that was screening at the point where we didn't have the testing capacity, and the screening, or indeed then followed on by testing. So the screening would stream people into either low risk, medium risk, or high risk categories, with low risk being having no confirmed or suspected COVID, medium risk being maybe suspected but not confirmed, and high risk being a clinically confirmed case of COVID. And so those were the pathways that people needed to be managed between those, because patients were cohorted within those pathways.
So we've heard about RHI, and we've heard about the screening on entry, but my question is to do with once people had entered the system, whether or not thereafter, before they were moved to different places around different wards, there was testing done or any guidance given on that.
So in line with the Infection Prevention Control Manual, again, NHS boards need to make their own assessment of the risk, taking into account the cohorting arrangements for patients and which pathway those patients were placed in, and whether there has been any change that would indicate that they've actually need to be moved to a different risk group.
And would your answer be the same in relation to guidance for staff to avoid staff members who were being placed or being used in one ward or deployed in one ward moving to others? Would your answer be the same for that?
That's right, yes.
Finally, in February, March and April 2020, and I appreciate when you came into post, what, if any, steps were taken to ensure that COVID-positive patients were not being discharged from hospital settings into care homes?
Yeah, so in March 2020, the guidance was that patients needed to be screened before they were transferred, and that should then be accompanied by isolation, so that patients should be screened, and then recognising that at that point the intelligence and the evidence about COVID was growing all the time, so we didn't yet have a full understanding of how long before symptoms presented itself somebody might be infectious, or how long somebody might stay infectious after they'd recovered. So the focus was very much on clinical screening and then on correct infection prevention control measures within care homes, including patients who had transferred from care homes to hospitals, needing to be isolated first for 7 days, and then the advice I think changed to 14 days. And it was, I think, the 21st of April when we moved to requiring 2 negative tests before patients were discharged from hospital.
I wonder if I may, my lady, ask one follow-up question. The question would be this: did you receive any feedback from care homes that the requests being put on them for isolation simply weren't possible to carry out?
I'm sorry, I'm not sure. I don't have an answer to that question. I'm sorry.
Is that simply because you weren't party to, you wouldn't have been party to those sorts of conversations?
That's correct. That's correct, yes.
My lady, that will perhaps be a matter for the next module. I'm obliged.
Thank you very much indeed, Ms Mitchell. That completes the questions that we have for you, Ms Lamb. As you know, I'm particularly grateful for the help that you and your colleagues have been providing to the inquiry, and especially today for you. So thank you very much indeed for your assistance. I'm sorry you haven't seen the back of me yet. I think that we're placing further demands on you in the next module. But thank you very much indeed for your help to date.
Thank you very much. Thank you.
My lady, the next witness is Professor Madeleine Arden. Oh, I do apologise. Please could Professor Arden be sworn?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Professor, you've got the last slot of the day. I hope you haven't been waiting all day.
No, I travelled this morning. Thank you.
Thank you. Could you please give the inquiry your full name?
I'm Professor Madeleine Ann Arden.
Thank you. Professor Arden, you were instructed by the inquiry to provide an expert report. And can we first look at that report, please? We can see on the front of the report that you were the lead author, but you had co-contributors. But can I ask you, can you confirm essentially the declaration relating to your expert report and everything within it is true and accurate to the best of your knowledge and belief?
Yeah, absolutely. I can confirm that. And just in terms of my co-authors, I'd really like to thank them. They really enabled this to be a true sort of Four Nations report with their contributions. So Professor Vivian Swanson from University of Stirling, Dr. Rhiannon Phillips from Cardiff Metropolitan University in Wales, and Dr. Gillian Shorter from Queen's University at Belfast in Northern Ireland really enabled us to they had that experience on the ground, so that was incredibly helpful.
Thank you. Well, if we perhaps move into the report, we in fact see at page 4 details of the authors, and we'll start with your own professional background and expertise, please. Thank you. It's right, isn't it, that you are a Professor of Health Psychology and currently head of the Centre for Behavioural Science and Applied Psychology at Sheffield Hallam University?
That's correct.
You're a chartered psychologist and registered health psychologist with 25 years of experience specialising in understanding behaviours and promoting behaviour change and maintenance across a wide range of behaviour domains.
That's correct.
Thank you. And then you've already, I'm only going to deal with that by way of your background, but the full CV of your expertise is detailed there. But if we go back, please, just to see the co-contributors, you've already identified them by name and location, but we can see there the academic and expertise background of Vivian Swanson, Dr. Phillips and Dr. Shorter, who you've already acknowledged by way of the contribution to this report, which provides an analysis of adherence to behaviours associated with test, trace and isolate system. Thank you. Now, can we then move to page 6, please, which I think gives an overview and your executive summary, but it's perhaps the most useful place to start, that really details what the view of you and your co-authors has been by reference to the documents you've considered, the academic research you've undertaken. And so can we start, please, at paragraph 1? You tell us that test, trace, isolate policies across the UK nations were central to the strategy to limit the spread of COVID-19 during the early phase of the pandemic. While there were some differences across the 4 nations, the approach was broadly similar, focusing on testing, initially in response to symptom identification, contact tracing and self-isolation. And I think you then deal with adherence to test, trace, isolate policies was complex. And so can I ask you then just to deal with, in your own words, the complexity that you identified in completing this piece of work?
So I think adherence, there were lots of different behaviours associated with test, trace and isolate, from identifying the symptoms to test, actually testing, then engaging with the tracing system, whether that was individuals contacting you or whether that was the tracing app. And then isolating. So there's lots of different behaviours, and many of them are pretty invisible. So we can see whether people tested or not, although we can't see people who didn't test, they're pretty invisible too. And in terms of adherence, really, we're relying on self-report data because we can't sort of observe people adhering to that. So there is some real challenges in terms of looking at that data and understanding it. There are things around how we sample. There's lots of surveys that we drew on in this work, but those methodologies, depending on how they sampled participants, reported quite different levels of adherence to self-isolation, for example. So we haven't got, if you like, the objective facts in terms of how adherence worked. We've got some kind of data that enables us to gather a picture. Just to say that's not unusual in behavioural science. There's lots of behaviours that we can only infer or ask people to tell us about, but it makes the job of it working out exactly what was happening quite challenging.
Thank you. And then can we look then next under the heading of adherence to test, trace, isolate? You identify that it requires 4 behaviours: identifying the need to test, testing, enabling contact tracing and self-isolating, and then deal with the fact that identifying the need to test in the next paragraph was inconsistent, with only half of respondents able to correctly identify the symptoms. Testing uptake remained low, even with increased testing capacity, and latterly, the availability of lateral flow tests as part of the universal testing offer.
Yeah, so even, the first step in that chain of events, if you like, definitely before the universal testing offer came in, was that we asked people to identify when they had symptoms and use those to go and test. But if we've only got half of people actually knowing what those are, we've sort of fallen at the first hurdle before we've even got onto the important behaviours, if you like. And the key important behaviour is self-isolating. That's what all the other ones are for. There's no point in testing if we're not getting self-isolation. So that was, we're having problems right from the start there. In terms of the universal testing offer, that improved things because we weren't so reliant on symptom identification at that point. But then there's other challenges to testing that I know we'll come on to in a moment when we further our discussion.
Thank you. And so it sounds fairly obvious and basic, but really is what you're saying, that there needs to be clarity as to what the symptoms of the virus is, because if those are known and somebody has them even before a test, it allows knowledge of the need to isolate.
Yes, I mean, potentially. I think the symptoms were really challenging because they're similar to so many other sort of infections, colds, flu, and actually the way in which people identify symptoms is related to their motivations around other behaviours. So it's not that stands alone, but certainly I think that not everybody knew what they were in the first place was problematic.
Thank you. Now you tell us in the next paragraph, key barriers to testing included misunderstandings of symptoms, as you've just dealt with, and a reluctance to test due to the potential for a positive result, which would necessitate self-isolation. Is there anything you want to say to expand upon that?
So self-isolation is not an easy behaviour to do. And actually it varies depending on your sort of position, your socio-demographic status. So for some people, self-isolation merely means working from home in a nice house with a garden For other people, self-isolation is incredibly hard. They haven't got the support, they haven't got the housing to self-isolate, they haven't got the finances to enable them to do that if they're in precarious employment. So we have a kind of a huge difference in terms of how difficult self-isolation is, if you like. And I think, and we'll talk about this more, I'm sure, as we go through, reluctance to test is related to whether people felt that they could self-isolate or not.
Thank you. And then perhaps building on the answer you've just given, can we briefly move to your chapter 3, which was the lessons learned, which I think perhaps very eloquently expresses your views on self-isolation. Can we move forward, please, to paragraph 381 at page 112? You say this self-isolation is an altruistic behaviour. It benefits others rather than ourselves. Self-isolation is fundamentally more challenging for some groups than others, and this produces and potentially exacerbates social inequalities. Self-isolation for people with professional, managerial jobs that could be done from home in comfortable houses with space gardens and the financial security of sick pay and the social support of friends and family is much easier than self-isolation for people isolated from friends and family, in precarious employment without sick pay or job security, living in a small bedsit with no outside space, who are worried about the consequences of having to isolate for their ability to pay the rent and to have enough money for food and heating. We need to acknowledge these differences and support people appropriately. And so is there anything you want to build upon what's perhaps quite eloquently expressed there?
I think it just illustrates there the hugely different ask that we were putting out there for people in different social situations, and that it's not a behaviour that's easy to do for many people, and I don't think that was sufficiently acknowledged in how we supported people.
Thank you. Can we then go back to page 6 of your report? Thank you. And if we can continue then in terms of your overview, you detail that contact tracing faced challenges with many positive cases and their contacts not being reached. Is there anything you want to expand upon on that overview point, please?
So, there's evidence that people were reluctant to provide details of their contacts, where they were worried that that would have knock-on effects on them, meaning to having to self-isolate if they perceive that it would be difficult for them. So that kind of runs through everything, I think. There were issues around kind of privacy and trust as well in terms of sharing contacts. So there were lots of, the data would suggest that we only reached a relatively small proportion of the contacts that, ideally we would have done.
Thank you. You next then detail that smartphone apps played a central role but were hampered by low usage due to privacy concerns and mistrust. Can you perhaps expand on that from your research?
Yes, so I think that the aim that was identified was that 60% of people needed to be using the smartphone apps for them to be sort of optimal in terms of tracing. But I think it was around 25%, certainly 20-something percent, I'd have to find the right paragraph. But so much lower usage than was hoped for. And I don't think that's particularly surprising, actually. People generally, I think what was missed here was that the smartphone apps required engagement with them to work. It wasn't just a thing that people had that would just work without people's engaging with them. Another behaviour we're talking about here. And there's lots of evidence, not just around COVID apps, but digital apps generally, that people are concerned about data privacy. They're concerned about how to use them. So that there was evidence that might be challenging, and I think we saw that play out.
Thank you. And I think the inquiry has the Every Story Matter record, where some of the experiences expressed in that record includes their concerns about information through the app and deleting it because of their concerns about privacy. Can we then move, please, to the next pointer? Self-isolation adherence was low, particularly among disadvantaged groups. Barriers included inadequate financial and practical support, exacerbating social inequalities.
Yeah, so as I kind of mentioned earlier, I think there were different situations that people were in. Many of the people in kind of key worker roles, for example, were out and about and being exposed to the infection more frequently, and therefore being asked to self-isolate more frequently, actually. And I don't think that's been acknowledged, that actually this wasn't as much as it should be. This wasn't a one-off thing that you did. It was actually something that people were often being asked to do repeatedly. And I think that idea that, you know, actually we needed to maintain this adherence over the course of the pandemic is also something that I think needs more acknowledgement and consideration.
Thank you. Now, we're going to deal next with the summary of the lessons learned for future pandemics. And this is summary. I appreciate that in the report you've gone into a lot more detail under lessons learning and your key recommendations. But I think it's a helpful way of looking at these in stripped back without the wider detail that we see in the full report, which will be published. You say this infrastructure and systems, e.g. testing, tracing, personnel, apps, were prioritised over policies and interventions to promote adherence. Behavioural science and health psychology should play a larger role in future pandemic responses. Could you provide a bit more detail about that?
Absolutely. So, I mean, clearly we needed a testing system, we needed tracing to happen, and apps were part of that response. There was a huge amount of investment in those things, but all of them require people to behave in certain ways, to engage with systems, to self-isolate. So behaviour was absolutely crucial to everything. And yet there wasn't, I don't think, sufficient acknowledgement that that was going to be a challenge, that was something that we needed to focus time and energies on to make that as easy as possible and to support people to adhere. And behavioural science and health psychology that's what behavioural scientists do. They look at, you know, the causes of behaviour, how we can create interventions and policies to promote behaviour change and behaviour maintenance. And I don't think that was central enough to the response, given the reliance on adherence that everything else was based on.
Thank you. You then identify paragraph 10, public health messaging must be viewed as an intervention to promote behaviour change, not just information dissemination. Messaging should be grounded in behavioural science and tailored to different population groups.
Yeah, so in the report, we kind of look at one of the key frameworks that we use in behavioural science and health psychology, which is the COMBI framework. And that says that in order for anybody to do a behaviour, they have to have the capability, the opportunity, and the motivation. So public health messaging shouldn't just be about telling people what they've got to do. That's only part of the picture, and that's not sufficient to produce change by itself. So when we're looking at public health messaging, actually it could do a lot more. So it could help people to increase their motivation to engage in things. It can help them understand the support that's available to them. So there's lots more things that it can and should do. And I think during the pandemic, it was viewed more as a sort of information tool and not as a behaviour change tool. And I think with more input from behavioural scientists, and particularly, you know, one of the things that behavioural scientists do is think about what do different people need, what do different groups need, and that might be slightly different. That would have been really helpful in the pandemic and would be really important for any future pandemic response.
Thank you. You detail that trust is critical to ensuring adherence. Changing guidance, mixed messages and lack of transparency damaged trust during the pandemic, as did instances of non-adherence from prominent public figures.
Yeah, I mean, we were having to rely on kind of trust and what we were being told, and we know that that's really crucial. It was difficult. You know, we had guidance that was changing as new evidence came to light, and, you know, we'd expect that, I guess, if it was a new condition, a new infection, we didn't know what we knew at the beginning, what we knew at the end. So, but what that meant was that the guidance changed frequently. People got confused about what they were supposed to be doing, and it wasn't really clear why things were changing. So that in itself can impact trust. The other thing that impacts trust, or one of the other things that impacts trust is, why are we doing this? It's about us. We're doing it for everybody else. At the point that you're self-isolating, you're not doing that for yourself because you've already been exposed to an infection. You're doing it to protect everybody else. And it's really important then that we are all doing that. And particularly prominent public figures need to be setting a really good example, being a role model so that everybody can see the value and trust that we are all there doing the same thing for each other.
Thank you. You then detail behavioural scientists work to support the pandemic response, but their advice was not always fully integrated into government policy. Formal channels must be in place for future pandemics to ensure their insights are used at national and local levels.
Yes, absolutely. So there were behavioural scientists in sort of that had roots through to government policy, so SPI-B being the obvious one. But I think SPI-B's documentation suggests that they had concerns that their advice wasn't necessarily impacting on policy. And I know there's some research being undertaken at the moment about the extent to which that happened. But there were behavioural scientists working across the board. So I myself was a member of, and this is a really long title which I've written down, this group, so I don't get it wrong. It was the British Psychological Society's Behavioural Science and Disease Prevention Task Force. And this was a group of health psychologists from across the 4 nations who came together to pool their understanding, their expertise, and to try to be helpful. But it was very difficult to actually be heard. We had some kind of local response to that. But these kind of channels, there's all this expertise. It needs to reach the right places and to be influential. And there needs to be, there's no point in working out what the channels are later on. We need those in place in advance.
Thank you. Now, we can see the summary of the key recommendations which are expanded upon later in the report, but let's work through these together now. You have recommended to align policies with barriers to adherence, detailing that different groups face different barriers and policies must be designed to address these specific needs. Fines should only be used when non-adherence is intentional, not when it's due to situational factors.
And that comes from the evidence that most people intended to self-adhere, but there was what's called an intention behaviour gap. And lots of the things that stopped them from actually adhering were around opportunity factors. So whether they had enough money, whether they had enough support, whether they had to care for an elderly relative and therefore leave their home to do so. So if we're fining people for things that they have to do, that doesn't seem reasonable.
Thank you. Now, I think
just pausing there. But the trouble is that if I had gone to work because I had to feed my family, I had to do it. In my view, do you find me or not?
I think we need to have proper support so that you if we're using it as an example, is not being disadvantaged by self-isolating for the benefit of others.
That I accept, but I'm going back to the principle of when you apply fines, because of course when you have a system of fining any criminal enforcement, you've got to make sure that it's got clear application and people know where they stand. And are you not suggesting that one has to introduce a subjective element as to whether or not I think, let's take me out of the equation, that somebody had a good enough excuse not to isolate? Do you see what I mean?
I do see what you mean. I think they shouldn't have been fined at all, because I think actually that had some knock-on effects in terms of people's willingness to test and engage with anything. Because if you can see that you may end up with a fine because you have tested positive, then you avoid testing. And there's certainly evidence from that from the Liverpool pilot, for example.
So basically, your approach would be to stop the problems I've talked about with having any kind of fining system that's subjective, because that's impossible to enforce.
Yeah.
You're saying move the emphasis to persuasion, messaging, away
and supporting
enforcement.
people to do what they intended and wanted to do, but felt they couldn't for various reasons.
Thank you.
So you would adopt the approach of Northern Ireland and Scotland on the self-isolation.
Yes.
Now, I think the next 2 recommendations you've already expanded upon already, but you've detailed that public health communications are behaviour change tools, and also the necessity to build and maintain trust. I think you've perhaps already spoken to those. Can we then move to invest in behavioural science? You detail that future pandemic responses should integrate behavioural scientists from the outset. Their expertise should guide research, policy and communications aimed at promoting adherence to health protective behaviours.
Everything we did in the pandemic required behavioural change, and behavioural scientists are the people that know how to do that best. So there needs to be kind of investment in that. There's so much less money going into research around behavioural science than there is many of the other things. It applies in test, trace and isolate, but also things like the vaccination uptake later on. And it's important that behavioural science isn't just a responsive mode, which I think is the kind of mode that it was used in the pandemic, because behavioural scientists can also identify areas that we need to look at that perhaps might not occur to policymakers. So generally, behavioural science behaviours are key, and therefore we should be investing in expertise in people who understand those.
Thank you. I think, again, the next three recommendations, again, we've touched on in looking at the overview. The recommendation of the need for accurate adherence data, support for self-isolation, but also the challenges of symptom identification. And so is there anything else you want to say as to those three beyond what we've already touched upon together?
I think the one thing around symptom identification that we haven't touched on yet is it wasn't just what the symptoms are, but there were lots of misconceptions that the symptoms needed to be really severe and long-lasting to warrant testing. So people were really reluctant to test if they had a symptom that wasn't very severe and didn't last very long. And that was about a sort of lack of understanding. We know, for example, that there were lots of asymptomatic people, and I don't think there was a sufficient communication that enabled people to properly understand that.
Thank you. You then recommend the need for supportive conversations. You say this: frontline staff and contact tracers should be trained to engage in supportive behaviour change conversations that enhance motivation and adherence to health advice.
Yes, so this is really important, I think. So contact tracers, they're doing a really difficult job, actually, because you're telling somebody something that they don't really want to hear, that they need to self-isolate. And it's not as simple as just saying, this is what you need to do, and expecting that people are going to stick to that. And actually, behaviour change conversations, there is a way to have a conversation around kind of adhering to a behaviour that isn't just telling people what to do. There are kind of methods to do that, which we've talked about in our report. In Wales, they did train their contact tracers using those kinds of methods. And I think that's really important, that it's, understanding that there is more sophisticated ways to support people to change their behaviour than just telling them that they need to do it.
Thank you. And you've also recommended the necessity to address equity issues. You detail that policies should focus on supporting those who find it hardest to adhere due to socioeconomic circumstances, ensuring the response is fair and equitable for all.
Yeah. Everybody was self-isolating for everybody else. It shouldn't have been so hard for some people to do that.
Thank you. And then you provide your overarching conclusion, which is this: the UK's test, trace, isolate strategy during COVID-19 demonstrated the importance of high adherence to health protective behaviours, but this was undermined by inconsistent communication, inadequate support, and limited use of behavioural science expertise. Future pandemic responses must prioritise trust, behavioural insights, and tailored interventions to ensure that public health policies are effective, equitable, and sustainable.
I have nothing to add to that.
No. Well, then, I have some specific questions that are in the report. So if we can then just work through some of those discrete topics, appreciating hopefully we've given a good overview of yours and your co-authors' views and recommendations. And can we start, please, at your paragraph 48D on page 13? And this is under your theories of maintenance. You outline theoretical themes relating to maintenance of behaviour, and we can see those set out at D, including the models and recommendations. Can I ask you then, does it follow that you consider this ought to have been recognised by or flagged by advisors to decision makers and factored into the development of TTI systems?
Yeah, absolutely. So we weren't asking people to do this once. We were asking people to do this repeatedly whenever they came into contact with an infection, whenever they needed to self-isolate. And there's evidence that we need to therefore give people some feedback on the value of what they're doing, for example. And those kinds of things weren't factored into the test, trace and isolate policy. I think we could have foreseen that there would be some people, probably particularly target groups like key workers who are out and about much more, exposed to more infections, that they in particular might need to do this thing, the self-isolation repeatedly. And so we needed to factor that in more.
Thank you. Can we then move to your paragraph 73, please, on page 18? Where you detail the review of how people respond to public health messages about managing risks and preventing infectious disease, and then obviously give the various examples, and also the review of the guidance document produced by BPS Task Force. Can I ask you, does it follow that you consider these steps ought to have been recognised by or flagged by advisors to decision makers and factored into the development of TTI systems?
Yeah, I think, how we got those messages out was really important. I think engaging different communities in the development of messages is something that we knew about, in advance of the pandemic, that actually we need to speak the languages of the people that are receiving our messages. And that means co-designing messages with those communities. I know in Professor Yardley's statement, she's been very supportive of that as well, that actually there are recognised ways of making sure that we are listening to and responding to the needs of communities in terms of how we use messages. So yes, I think this was known sort of before, and I think this should have been considered in how we responded and how we developed those messages.
Thank you. Can we then please move forward to paragraph 81, please? You've helpfully provided a table relating to the financial support that was available across the 4 nations. And then, thank you. If we can then just move forward, having identified that table, please, to your paragraph 259 on page 80. That's paragraph 259, please, on page 80. Thank you. You detail there in respect of particularly Wales, albeit there's an analysis that's done of each of the 4 nations. You detail that for Wales, the payment scheme did not formally open until the 16th of November 2020, and that this delay between announcing support and enabling claims to have been made would have been challenging for those who were eligible, given that they would have been on low incomes and in need of timely financial support. Can you comment on the impact of delay? And I think there's some evidence of that across the other nations, but can you comment on the impact of delay in providing financial support on adherence to test, trace, isolate behaviours, for example, in relation to identification of the need to test, testing and or self-isolation following a positive test? Absolutely.
Any kind of delay is going to be problematic. There's the actual delay that people experience, for people on low incomes who are relying on a weekly wage, for example, then having a delay in being able to access that means that, people don't have money for that week. But I think there's also an impact on motivation, because if you perceive that you may not have access to that money, then that's going to mean that, the next time you need to self-isolate, you're also going to be less motivated to do so, because you have less confidence that you're going to receive the support that you need. So any delays, whether they're still happening or whether they happened before, you may still be worried that they're going to happen again. So I think, we needed those support systems in place as soon as possible. And in terms of thinking about any future pandemic, having a system in place so that we know how we're going to do that in advance would be incredibly beneficial.
Thank you. Can we then move to your paragraph 118, please, on page 36, where you offer an observation on contact tracing. You detail the extent to which the contact tracing systems were centralised or used existing local systems differed across the 4 nations, with England and Northern Ireland using a national approach and Wales and Scotland using a local system that utilised existing healthcare system, and that England moved towards a more local response in the summer of 2020, following criticism of the national approach, which relied too much on inexperienced contact tracers and not enough on public health teams with local expertise. Are you able to provide any further detail as to your overall view of how the responses compared between the 4 nations?
I mean, I think, local public health teams have got a great deal of knowledge about their local communities, how to communicate through trusted leaders, things like that. So they have lots of knowledge. As I mentioned earlier, the job of contact tracing isn't as simple as contacting people and saying this is what you've got to do. And I think where we used a national system where we were rapidly training people to deliver a really skilled thing is problematic. And so it was much better in places, and obviously England moved from one to the other following criticism, using that kind of local expertise and local skills in having those kinds of conversations.
Thank you. Can we next move to your paragraph 144, please, on page 43? You detail under test, trace and isolate as a system of behaviour that interventions to increase adherence need to consider behaviours as an interconnected system, and that people are likely to be unwilling to increase testing if there remain substantial barriers, a lack of support for self-isolation, given that this is a direct likely consequence. Critically, this lack of support hits those living with deprivation more profoundly than for those who are more affluent. Would you agree that the barriers you've detailed here were firstly foreseeable and secondly predictable?
Yeah, I mean, I think that kind of interconnected nature of the behaviours is something that's really important. And I think we could have foreseen this. And I think this is something about when we are looking at something and considering the motivations of different kind of people within that system. So in terms of the motivation of policymakers, clearly the kind of purpose of all of this is to stop the spread of COVID. But actually, if we think about each individual, they've got a huge number of other things going on in their lives. And I think we'd all accept that the kind of key motivators for human beings is, looking after families, having enough food, having housing over their head. So I think, we could anticipate that where the system that's being proposed is going to be particularly challenging, then people will withdraw from engaging with it. And in this instance, that would mean avoiding getting a test because you can foresee that will have negative impacts on kind of really core values that you have as an individual in terms of looking after your family. So yes, I think it could have been anticipated, and I think we needed to look at these things in a much more joined up way and acknowledge that kind of across the whole of policy making.
Thank you. Can we next move please to your paragraph 155 on page 47, where you detail the substantial differences in ability of people to correctly identify the main COVID-19 symptoms and then reference the barriers. Can I ask you, in light of this, would you agree that in circumstances where language barriers or differing cultural behaviours exist, there can be significant benefit in healthcare workers who belong to the same communities as those receiving the information, communicating and helping them understand in terms and language that will interpret and explain the information clearly to them?
I think, yes. I mean, it could be healthcare workers. I think that would be one way to do that. I think we generally needed to think about how we could deliver those messages to different ethnic and cultural groups. There, in the report, there was I detail some work done by Atia Kamal and colleagues looking at how messages needed to be both developed to suit different communities, but also how they were delivered was really important for those different communities. So that could be by healthcare workers from the same cultural groups. It could be by local leaders in those groups. I think we needed to make use of all of the kind of community contacts that we had to make sure that those messages were reaching people in a way that they could understand.
Thank you. And I think you've also highlighted there the statistics from the Office for National Statistics that 5 million people in the United Kingdom speak a primary language other than English. And so again, using paragraph 155 as the foundation of this question, do you believe that these disparities in symptom recognition suggest that highly important government messaging firstly lacked nuance and specificity and was thus not sufficiently tailored or designed to reach all groups in society?
Yeah, I think that's absolutely the case. There were certainly some delays between the guidance coming out in English and then it being translated into other languages. And although those weren't hugely long delays, they're still very important ones. And I think we could have anticipated at a minimum that we needed the guidance in the kind of key languages. I think there is also other work in terms of making sure that those messages are being provided in ways that suit different cultural groups, and I think co-production, so working with those groups to make sure that the messages work for them is a way to go about doing that.
Thank you. And again, on the issue relating to government messaging, would you also have any views as to whether it failed to be sufficiently accessible to resonate with the lived experiences of some minority communities?
Yes, certainly. I think there's lots of evidence that that's the case. There were some kind of messages that were, so for example, the messages about why the guidance was changing was missing from most of the public health communications. So unless you were the kind of person who was watching the daily briefings where maybe that information was given, you didn't hear that. And I think we need to acknowledge that actually that why things were changing was really important. And there weren't the same kind of efforts made, I don't think, to make sure that that was understood across different groups.
Thank you. Now, can we move then to your paragraph 187, please, at page 57? Again, you give a section on data on the percentage of people requesting a test. And similarly, I think over the page you give the data in the figure that assists with self-reported behaviour, intended behaviour, and capacity under Pillar 2. Can I ask you then, there's clearly, from your report and this figure, a relationship between testing capacity, compliance with self-isolation and perceptions at play. Can you explain why and how testing capacity issues in the United Kingdom may have impacted upon compliance with self-isolation?
So I think this relates to the fact that these are all linked behaviours. So we've got kind of testing being linked to self-isolation, but the harder we make something for people to do, the less likely they are to engage with it. So if we're requiring people to go and travel to get a test because that's the only place that they are, then people are less likely to do it. So I think we have those kind of, logistics, opportunity issues in terms of testing. But I think we've also got the fact that even when there's certainly some research studies that we refer to in the report where even when testing capacity had increased, there was still a perception that there was lowered testing capacity. So people were still reluctant to kind of engage with it even when the capacity issues had been resolved. So I think it's important for people to feel that they are able to access a test in the easiest way possible. And that was certainly more challenging for people in some communities, rural communities, for example. I know in Scotland, they kind of address that with things like fire stations offering testing to try and address some of those things.
Thank you. Can we then move forward to your page 72, please? Thank you. And can we specifically look at paragraph 226, where you detail that the low level of adherence to self-isolation in the United Kingdom compares dramatically to places where support for self-isolation was provided, which had higher rates of adherence. And the example you give is New York, where people were provided with money, hotel accommodation, food and mental health support. And also that there were multiple calls during the pandemic for there to be better support for self-isolation. And so can I ask, do you agree that it's clear that adherence to self-isolation and sufficient support are interconnected?
Absolutely.
And the study you cite there, which is quoted in paragraph 226, suggests that the deficiency in the data makes conclusion equivocal. However, would you accept that nonetheless that the data in international comparisons do provide valuable insight that should have been used to inform government planning and decision making at the time?
Yeah, I mean, I think that particular study was equivocal. I think if we look at the international picture, there is a lot of evidence that was important. If we look at the theory from kind of behavioural science, if people, are struggling to do a behaviour, then they're not going to do it. And having sufficient money and support, that may be accommodation to enable you to self-isolate or mental health support are absolutely critical. I don't think, there were so many different groups calling for self-isolation support. SPI-B were, Independent SAGE were, as well as various papers. There were so many calls for it, and I agree with them.
Thank you. And so can I ask you, would you have views as to whether the United Kingdom did not take sufficient notice of TTI systems in other countries during the pandemic to help inform our responses?
I think if we look generally, I think it's, the comparisons are quite difficult. There are lots of differences around kind of different cultures, different ways of doing things. But I think if we're talking specifically about support for self-isolation, then I think the messages were clear.
Thank you. And you say the messages are clear, but can I ask you, could those international examples have taught the United Kingdom in respect of the design and adaptation to self-isolation support?
Yes, I think so.
Thank you. Can we then move to the next paragraph, please, over the page at 73, para 227. You talk about the evidence of the impact of financial support coming from both other pandemics and international responses to the COVID-19 pandemic, and obviously reference the fear of the loss of income. And obviously the learning from the swine flu outbreak. Would you agree that clearly these factors were known at the time and should have been part of the government's planning and decision-making process in relation to self-isolation rules in the United Kingdom?
Yes, I think so.
Thank you. Then if we can go to paragraph 229, please. Again, you detail there about the benefits of financial support for self-isolation. Can I ask you, throughout your research, have you identified evidence that explains this omission or how it arose?
No, I haven't. I think all of the evidence I've seen in terms of what was being recommended is that people needed sufficient support to be able to self-isolate. Just to be clear, this isn't a reward for self-isolation. This is addressing the kind of shortfall in income that people were experiencing. And I think, it was really clear that that was needed.
Okay, just two final questions from my perspective, please. Can we then look at paragraph 232, which is there on page 73, where again you talk about self-isolation payments. I know you've had an opportunity to review the expert report of Dr. Richard Matchin, who we'll hear from tomorrow, and considered his report. Now, Dr. Matchin suggests that future self-isolation payment schemes will be more efficiently administered and provide a higher level of financial support if administered as part of a centralised job retention scheme. Can I ask you, and particularly in light of what you say at paragraph 232, do you consider that financial support ought to have been universal and paid by the employer rather than retrospectively following an application process?
So I don't think I've got expertise on how financial support should be paid, but from a behavioural science perspective, in terms of how this might influence adherence, the key thing is that people need to access that support easily and be really confident that they will get that support. And, universal payments is one way to do that, because then everybody knows they're getting the payment. But, I acknowledge there are also downsides to universal payment. The key thing from a behavioural change perspective and adherence perspective is that those payments are really clear. So Dr. Machin's report also kind of outlines that the people who most needed that support were the least likely to know about it. So we need to make sure that that support is really easy to access, that people know that they can access it, and we need to use the contact tracing system to make sure that they know that they can access that. People can feel confident that they're going to receive that support in a timely fashion, and that's what will impact adherence. So I don't know how that is best done. I'll leave that to the experts in that field.
Well, we'll ask Dr. Machin his views tomorrow. And then finally, by way of the particulars paragraphs that I seek your further assistance, can we look at paragraph 340, please, at page 104, and under the banner of trust, which we've already touched upon. You detail that trust is central to engagement with public health policies, and for adherence to protective behaviours to be maintained, there needs to be trust in the long term. You then detailed that data from a large weekly online panel of UK adults during the first 3 months of lockdown showed that there was small association between increased confidence in the government to tackle the pandemic. Then can I ask you finally, given it was known that ethnic minority groups generally have lower levels of trust in government and state authorities, do you consider there ought to have been targeted intervention to build trust within these communities in order to increase chances of adherence to TTI measures?
Yeah, absolutely. We know that that's well known that there are some issues with trust. We also have evidence from kind of other sort of areas of public health that the best way to build that trust is to work with those communities. So that's around co-designing the approaches, making sure that people have their say in them. Again, who I mentioned earlier, Professor Yardley's report details this as a really crucial way to build trust that we needed to adopt. Obviously, there's an issue of that takes some time. You can't just suddenly co-design a policy, and obviously there were time pressures to do that. But I think some of that work in terms of things like people's willingness to engage with digital apps, for example, could be done in advance of another pandemic that we all hope isn't going to happen. But some of that work around how people might feel about those, what kinds of features people might want to be able to turn off, for example, is something that we could do in advance. But that's certainly the best way to make sure that the policies are more trusted by different community groups.
Thank you. I'm just going to give the reference to Professor Yardley's statement that you've referenced now on a number of occasions. So for completeness, that's INQ 567607. Professor Arden, those are my questions. My lady, there are some core participant questions.
Mr Dale. Mr Dale is over there, Professor.
Thank you, my lady. Professor Arden, I ask questions on behalf of the Federation of Ethnic Minority Healthcare Organizations, or FEMO, and I have 2 short topics that I wish to explore with you. At paragraph 180 of your report, you note that issues of lack of trust in the COVID-19 app have been identified in a number of research studies. Quote, with Black and minority ethnic groups reporting particularly low trust in the app, and that trust decreased further over time, again in quotes, as a result of awareness of the failures in the technological capabilities of the app and lack of evidence of its effectiveness, end of quote. My short question to you is, do you consider enough was done by way of targeted intervention to address the low trust of minority ethnic groups in the app?
I certainly think more could have been done, and I think there was a focus on getting an app that worked functionally in terms of the tech, and not enough focus on how people would engage with it. And that is really about the kind of trust that people might have in it. It required a lot of trust in that app to use it. You were trusting that it was working properly. You were trusting that what it told you about whether you were exposed to an infection was accurate. There was things around kind of it tracking your movements. We know from other studies of sort of digital apps that there are some concerns. And in terms of Black and minority ethnic groups, studies showing that that's particularly particularly the case. I think that relates to the comment I mentioned earlier, that the best way to kind of resolve that would have been to make sure that the apps were co-designed with people. We needed people to use them. People needed to be more involved in the design of them. We needed people to be able to use some but not all of the functionality, perhaps. So it was a bit of an all or nothing kind of app. You either used it or you turned it off, and many people chose to turn it off or not to download it at all, whereas perhaps if they'd have been able to kind of use it in a way that was more controllable. But we'd have known that if we had properly listened to the voices of different groups and co-produced the features of those apps, and I think that would be the way to go forward.
And you might have answered this question before, but just now actually. But what would you suggest ought to have been done to address this issue?
So I think making sure that the groups that we wanted to use the app were involved in its design, making sure that people could say what they would do. Would they engage in an app that did this or that, or you had to scan an QR code, and or the features that the app had, and they changed a bit over time. Were people going to find those acceptable? Would they engage with them? And I think the levels of use of the app would suggest that there were some significant problems there that weren't sort of designed in at the beginning. So that making sure that people have a say in designing those apps is really important. And behavioural science is a sort of way to make sure that we're understanding how people engage, and engagement being a behaviour.
Very helpful.
Thank you, Mr. Dale. Mr. Weatherby, who sits just there.
My point's been dealt with. Thank you very much.
All right, thank you very much indeed. That completes the questions we have for you, Professor. I do appreciate the amount of work that went into the report, and you may think we've rather skimmed over a lot of it. Please don't worry. As Ms. Cartwright said, it will be published, but also I'll ensure that I read much more. I take into account all the material. Some people think it's just the evidence I hear here already, but it isn't. It's all material. So thank you very much.
Thank you.
And please pass on my gratitude to your colleagues for their assistance too.
Thank you.
Thank you. That completes today's evidence. I shall return for 10 o'clock tomorrow.
Thank you.